All right, welcome. This is the CRS questions for IEA. I'm doing cardio first. This is the thing I've said before. I'm gonna finish. I'm like here, if you can see. I'm gonna finish cardio and then do renal. My exam, as I remember, was more cardio heavy. I'm gonna move this out of the way by clicking here, and then I think I've done this question. And also, I'm more fresh on these topics since I'm in term 5 now, and I'm kind of doing questions on random. Actually, from here on, I'm just gonna do cardio, right, and then renal. So, 24-year-old man, fainting. Okay, fainting in a cardiovascular context is like not enough blood to the brain, right? Uh, Breathlessness. Physical examination finds presence of heaves. Uh, Displacement of point of maximal impulse. So when you have, this is like your thoracic cavity, let's say. So this is your patient's left, this is the right. Heart is usually here, right? Now displacement, this is the point of maximal impulse here. If it gets bigger, you get like displacement to the side, right? So that means just the heart is bigger than normal. So far we got heart sometimes can't pump blood because of the fainting spells. Now we've got point of maximal impulse is moved laterally. Okay, so the heart is also bigger. Further testing shows ejection fraction is preserved. Okay, so let's keep that in the back of our mind. And then this is a key word here: asymmetric hypertrophy of left ventricle. I don't like it when people look for keywords and shit like that. I think that just means you're not understanding the medicine behind it, and that strategy. Good luck using that strategy in term 5 or just like as a doctor. So I recommend not building habits like that. But when you have a heart, let's say these are the atria and this is a ventricle. So there's this thing called hypertrophic obstructive cardiomyopathy, right? And basically, remember, if this is the aorta coming off the heart, right? If this is the septum in the middle, if it gets thickened and like more thickened than normal, it will stop blocking the outflow track. You know, the outflow track, this track, right? So it describes the hypertrophic obstructive, because it obstructs this pathway, cardiomyopathy, right? What is it due to? It's a genetic condition, presentation usually in a young guy or young girl, right? You get fainting, you get hypertrophy, right? And a lot of times the question is like this young guy or girl just like passes away out of nowhere. And after like playing a sport or something like that, usually like cardiovascular activity triggers it. The gene is autosomal dominant, right? Affecting the sarcomere proteins, and we got affecting the cytoskeletal proteins. Okay, so it's not tryptophan cruzi, right? This is, I believe, I think this is Chagas disease, right? You get dilated cardiomyopathy, right? Dilated cardiomyopathy usually, first of all, like young guy, like these all point to hypertrophic obstructive cardiomyopathy, but also dilated would point to what? It would point to reduced ejection fraction, and this guy has normal ejection fraction because that's what dilated cardiomyopathy does. It reduces ejection fraction. Type 2, whatever, this is like rheumatic fever. This guy doesn't have rheumatic fever. Patchy variable interstitial fibrosis of the myocardium. I think this is like the myocardial fibrosis thing, and this is just not a description of that. So we got cytoskeletal proteins, and we got autosomal dominant mutation affecting the sarcomere proteins, right? I want to confirm this, so I'm gonna look it up quickly on Amboss, but I think what exact the mutation is. But so basically, a couple mutations that are important for the heart. One of them is the Titin gene. Titin is for dilated cardiomyopathy, right? That's one, right? You got two that are for the hypertrophic ones, but I think they're both sarcomere proteins, right? They're both sarcomere proteins. I'm gonna get their exact names. So even Amos didn't talk about exact mutations here for dilated obstructive type. But just know that it's a sarcomere protein, right? Cytoskeletal protein, it's probably the Titan one, the TTN, or really what this reminds me of is Duchenne's muscular dystrophy and Becker's muscular dystrophy, Titan, but so this is sarcomere protein, and I think the actual mutations is something to do with a myosin, like myosin light chain, something like that, right? Oh yeah, thank God. I haven't looked at the answers, so if I get something wrong, just know that it's not because I don't know, it's because these questions are sometimes a little shitty, okay? I know everything. I'm really humble about it. Anyways, 2-year-old boy, fingers and toes have been turning blue, okay? That cyanosis, whatever reason, probably if it's a little young boy. Wait, I already done this. Okay, I'm gonna explain it real quick. What, have I done these? What is going on here? Shit, I think I've done them, but I haven't published the videos. Oh well, I'm gonna do them again. So, boot shape, right? Overriding aorta. This is tetralogy of Fallot. 4 things are important here, right? One of them is, first of all, like, this is the way I remember it, and this is the way you should remember it. One, what ends up happening in the pulmonary artery or pulmonary outflow tract gets stenosed. Okay, and that leads to, so if your pulmonary outflow tract is stenosed, then your right ventricle is hypertrophied, and then you got right ventricle high pressure. This is high pressure. Okay, now when you have right ventricle high pressure, what ends up happening is when your heart is developing, like the septum, if this is your heart, the ventricles, the septum is like kind of like building itself up and down, and if you have high blood pressure here that like pushes blood like this way all the time, it will have a harder time closing, so it won't close, so you have a ventricle septal defect. And the other thing is, this last one you kind of got to remember, that the heart is like a little bit malformed. So one of the reasons that this happens is that if this is your heart, instead of developing like this, like the septum from the top and septum from the bottom joining right in front of each other, it's like kind of like this, like septum from the top is here, from the bottom is here, so they're not like kind of like in front of each other. That's also what causes the stenosis of the pulmonary outflow tract, but that also means the aorta that's going to be here is going to be right in front of this kind of the shunt gets created. Now, so we got overriding aorta, right? So important thing here that predicts prognosis, meaning how bad it's going to be, is outflow tract stenosis. So A. So here we got a 75-year-old elephant. So has got finger compression in the chest. So probably MI, right? SC elevation. Streptokinase is given. and then he develops arrhythmia, right? Why? Why? Uh, Reperfusion injury, right? Okay, so why does that happen? You have a heart, right? These are the vessels this time. This vessel gets, usually is open, right? And then now it gets occluded, right? This area of the heart isn't getting blood anymore. It still doesn't die right away. You have a little bit of time. So there is this therapy that comes in, like kind of like breaks that clot down. Now when you break the clot down, the area of the heart that I kind of like here, let's say this area, that's fed by that, it's kind of used to low levels of oxygen, right? It like down regulates its like antioxidative mechanisms and stuff like that. So when you like reperfuse this, when like new blood comes in, it brings a lot of oxygen and kind of new O2, and it kind of damages the myocytes. So and you get a perfusion injury, and it's done to do with a lot of calcium. A lot of calcium comes into the cells and causes hyperexcitability of the cell, right? Okay, so 58-year-old, tearing pain in the abdomen radius to the back. So pain that radius to the back is usually here. This is imagine this is the AP section. So this is like a thorax of a guy, but like this is the front, this is the back. We are seeing it. It's like an X-ray. We are seeing the back, right? We're seeing it from the side. This is the diaphragm, right? And like all the gut structures are here, right? And then this is like where it goes down the anus, right? There's this thing called the peritoneum that like kind of encompasses all this. It goes around all the gut and it kind of creates a layer here, like towards the end. And everything that kind of like lies behind it here is called retroperitoneal. A bunch of important structures fall here, like, but some of the important ones, for example, that come to my mind is the aorta, vena cava, some of the kidneys, the tail of the pancreas, right? What else? Like some of the rectum, ascending and descending colon, kidneys, ureters, all that shit, right? So when you have like inflammation or something happening there, you feel the pain back there, right? That's why like pancreatitis sometimes has pain in the back, right? Now this guy, that's why you get to see so this guy has a problem with his aorta, right? And kind of the tearing sensation should tell you about that. And he has a significant history of hypertension, smoking cigarettes. So this is a abdominal aortic aneurysm, right? Basically, let's say your heart is here, right? Aorta comes down here. It can have an aneurysm here or here, right? This is the abdominal type one. Why? This is kind of a clinical picture. You gotta see what is the guy like. The guy has like a lot of smoking experience. So actually, let me explain it this way. The risk factor for this one, the most important one, is atherosclerosis. Atherosclerosis, right? So the way that happens, if this is the vessel, right, usually, aorta up here, it has these little vessels called vasa vasorum, which is kind of like vessels that are like running longitudinally around the aorta that are here. So it kind of feeds the wall of the aorta. Down here, it doesn't have that anymore. It just like loses it through like, I don't know why. It's normal to lose it. So down here, it's more susceptible to kind of like hypoxic problems. Now, when you have kind of like atherosclerosis, you're thickening this shit, right? You're thickening this. And what does that lead to? That leads to the media kind of like not getting enough oxygen and kind of dying, right? Okay, so atherosclerosis is the main risk factor. What does contribute to atherosclerosis? Hyperlipidemia, type 2 diabetes, but more importantly for this, classically in an old guy and smoking. So old guy and smoking go really hand in hand for this, right? To the point that if you have a guy above 65-year-old and if you haven't even diagnosed him, right, and he's been smoking a lot of cigarettes, you gotta like it becomes one of the like screening things. You gotta screen for it because you're like, this happens so often in this age bracket now. Now, for the one that's up here, if you have, this is usually two things can cause this, and one of them is very high hypertension, right? This is the one that like involves a lot of tearing. So this one, like on CT scan and stuff like that, looks like an aorta, and then looks like there's a different layer. So it's because if this is the vessel, it kind of like, let's say this is the vessel longitudinally, this is the upper wall, this is the lower wall, right? The blood is so like it kind of goes down here and creates like a false lumen here, and then maybe it finds a way to come out. So when you like cut through like this, you see something like this. This is because of hypertension, right? And these are thoracic like tearing aneurysms. It's just a tear. I wouldn't call this an aneurysm, right? So aortic tear. This is because of hypertension. And there's also syphilis. So remember I said there's these vessels called vasoviscerum. So it's the vessel, right, that run around the aorta, and they're only like up here. So in syphilis, the bacteria damages these small vessels, and in general syphilis damages the small vessels, and that's how it causes its problem. So it damages these small vessels. I say vessel funny today. Anyways, it damages small vessels, and then you get the same problems up here. So you get a dilate, like you get a lumen that's dilated, right? So you have a thoracic aneurysm. So the three types I'm going to go over: abdominal aortic aneurysm. Again, this one, risk factor for smoking, right? But don't memorize this. Kind of know why. Why is it smoking? Because it's atherosclerosis driven, and honestly, if you don't memorize why, you're wasting both my and your time, right? Or if you don't know the why, if you're just memorizing. So atherosclerosis dominant, smoking, big risk factor. The top ones up here, you can either have a tear that is like blood going into the lumen and coming out, and it kind of making a false lumen, right? This is because of hypertension. And you can have like a general dilation, like the one you have here. It's just like it gets dilated because the walls get weak, and that's because of destroying the vasa vasorum via syphilis, right? So smoking for this one. This is wrong. Actually, I remember doing this question now. This is wrong. I can verifiably tell you that this is wrong, and it's a rookie mistake. The reason for that this person went for hyperlipidemia is that hyperlipidemia is a risk factor for atherosclerosis, and the person kind of thought, oh, like, yeah, that makes sense. Or maybe this is just an old question, but it's been proven that smoking is the biggest risk factor for this. Certain things, smoking, in the NBME, which is the National Board of Medical Directors, whatever, I don't know, something. It's the organization that writes the STEP exam. There's gonna be a lot of questions that the answer to is smoking, because smoking is the single cause, like single-handedly causes a lot of problem, basically, more than anything else. So if you have a patient who's like smokes, is fat, doesn't exercise, eats like shit, drinks a lot of alcohol, the best thing they can do for their health is to cut out the smoking, right? And you will see questions like that in UWorld and like other resources. Okay, 42-year-old guy, runny nose, past 2 weeks, that has been seen by other physician. Medication for sinusitis, has no improvement. Okay, so it has nose problems. Okay, I'm gonna skip down here. Ulcers in this nurse, right? Cianca. Okay, so this is Wegener's. So Wegener's has 3 areas it hits, right? The nose, the inside the nose mucosa, the lungs, and the kidney. And also you'll see like cutaneous lesions and stuff like that. So what is the question asked? Red cell casts. Okay, so the kidney, it causes nephritic. So it causes nephritic syndrome. Seen on X-ray, mediastinal widening. Alright, let's read. Bilateral nodular infiltrates. It's kind of like reminds of an infection of some sort, pulmonary edema. Unilateral. Okay, I have my answer. Bilateral nodular infiltrations. Interesting. Okay. What could it be? Definitely not one of these 3. Okay, pulmonary. Yeah, just know that Wegener causes as a part of the lung, causes A, bilateral nodular inflammation. I mean, it damages the lungs, right? Now, it's definitely not in the form of edema, right? It's definitely not unilateral because it's a systemic disease. Mediastinal widening, this kind of reminds me of heart failure, so I wouldn't go with that. The only other one that could kind of make sense is hilary lymphadenopathy, but what condition is hilary lymphadenopathy predominant in? The answer for that maybe is like more of an RHS question, but the answer for that is sarcoidosis. And this is really important. But bilateral nodular infiltrations actually does make sense because it's nodular, right? So there's nodules of lung involvement and they're spread through, they're not in one side. It makes sense for a systemic process, right? Okay. 33-year-old has M1, M2. Popping noise is heard. The memory gets louder as it approaches S2. Okay. Not a feared complication, right? What's the diagnosis here? You got a popping noise. So I think it's chronic rheumatic fever. Right? Popping noise. Sorry, popping noise. It's not chronic rheumatic fever. It's this guy is probably really tall. Okay, so let's talk about what happens. I'm just gonna draw the left ventricle. Right, it's the septum. This is the ventricle, and this is where the blood comes in. This is where the blood goes out. Let's draw the mitral a little better. Let's draw it a little better. So it's like kind of like comes in like this, and then there's like these cords that kind of connect it to the wall of the ventricle, right? Now, in this condition that this guy has, I'm gonna draw it with a different color. What happens is that these guys stretch a lot, and when they stretch, like at some point, like they kind of prolapse, like they kind of pop, right? They create a gap, and that's a pop sound you hear, and then some of the things gets out. Why is it stronger as it gets to S2? So these cords, the chordae tympani, as the ventricle is contracting, are shortening, so it's creating a bigger and bigger gap for these guys to prolapse, right? So okay, now it's kind of a mitral regurg, but it's really a mitral prolapse. Who is at risk of having this? Marfan syndrome. People with Marfan syndrome, and people with collagen problems in general, but Marfan syndrome. Okay. It's probably one of the more common causes of their death, but characterized by the popping noise that happens in the systole because the ventricle has to be contracting, and then happens later. And the other point is that the earlier you hear the popping noise, I think the earlier you hear the popping noise, it means it's worse because it means the cords don't have to even get that close for it to prolapse like this, right? But that's a kind of a more harder concept. Let me actually write it down because I want to look some of this up later, because that's how medicine is practiced. Is you like go through stuff and you realize like, oh, maybe like I need to look this up again. So what am I gonna write down? I'm gonna write down sounds of mitral valve prolapse. Okay. Now, where were we? So when you have mitral valve prolapse, right, or any form of mitral valve kind of deficiency that you have regurgitation of mitral valve, a couple of things can happen, right? First, your heart has to work harder because every time it beats, like instead of like pushing 100% out this way, it pushes like 30% out this way, and like some of it goes out this way. Maybe like 70% out this way, and some of it goes this way, depending on how bad this, the prolapse is or the regurgitation is. So it does cause congestive heart failure, right? It does cause thromboembolic stroke, and the mechanism is a little interesting. Imagine this is your kind of like left ventricle, right? Again, this is your outflow tract. This is the atrium is here, right? So this is left atrium, and this whole thing is your left ventricle. Because the blood keeps going back, it will increase the size of the left ventricle. When the left ventricle gets bigger, the electrical activity gets a little abnormal there, right? So it causes you to have AFib. So you get AFib. What does AFib cause classically? It causes embolisms in this right atrium. Okay, so you have a little emboli here. It goes down, goes back up. So you get it, and then goes back up, goes anywhere in your systemic circulation. Most feared one is obviously your brain that causes stroke, right? But it can cause it anywhere. Actually, I already have it written down here. Okay, sudden cardiac death. Maybe you get an arrhythmia. Maybe you get an MI and then an arrhythmia, right? But sudden cardiac death is usually due to an arrhythmia. Now, arrhythmia can have different causes, right? Maybe you have heart failure that leads to arrhythmia. Maybe you have an MI that leads to arrhythmia. Superimposed bacterial infection, yeah, because when you have valve damage, see, some of these things like this didn't come to my mind now, but thank God I have it here. When you have valve damage, because this valve is like getting overworked, you might have superimposed bacterial infection. So the answer for this is tamponade. Now, when can you get tamponade? One thing that comes to my mind actually is that, remember we talked about this, right? This tear here. If this tear goes back enough and it gets to like where the aorta comes out of the, let's draw the heart again here. This is the same with drawing both, and then the aorta comes down here. So the tear, if it travels back up, tears more and more. If it gets here, then it bleeds into the pericardium. Pericardium is a layer that's like kind of like covers the heart, and then if it bleeds into pericardium, it pushes down here. It kind of like stops the heart from expanding. So, and one thing that's characterized by that is that the heart sounds will be muffled, right? Muffled heart sounds. The other thing is that because the heart, it can't expand, blood from the vena cava can't go back in it, so you get blood backing up into your neck veins. So that's so you get distension on neck veins. That's I believe known as the sign is Kussmaul sign. Right. So let's look at this. 60-year-old has a left anterior descending artery infarct and gets drooping on his face, and then you have a dilated left ventricle. The answer was mural, right? So basically what happens here, when you have, let's talk about sequences of MI, right? So you have like from kind of like 0 to 4 hours, you really don't have much happening, right? From a pathological perspective. So when you take a sample, it doesn't look like anything's happening. From 4 to 12, you get like your baby fibers, right? This is like cells starting to die and stuff like that, right? And then you have from like about 12-hour to like 3-day. And okay, I'm also gonna say what the common cause of death is, right? So the common cause of death here, like this soon, is because of arrhythmias, right? Arrhythmia or just heart failure, right? Heart failure, your heart can't pump in any more blood, right? Arrhythmia, basically, like the electrical activity. There's a problem with the electrical current, and like there is no way you can't recover from that, right? You just die. 12 hours to 3 days. So this is where the neutrophils come in. So the neutrophils, right? Neutrophils kind of feel like dying cells. The stuff from inside the cells like kind of gets everywhere, and then it activates your like immune system. If you remember from term 3, these are called DAMPs, damage associated molecular patterns, as opposed to PAMPs, which are pathogen associated molecular patterns. Basically, your immune system recognizes shit. Like there's like myocyte guts out here, so neutrophils are the first one that gets activated. Uh, what's the common thing that happens here? Let's see if there has it. No, yeah, autoimmune pericarditis. So acute autoimmune pericarditis because these the neutrophils secrete a lot of fibrin and it causes fibrinous pericarditis. Nothing else comes to my mind because of death. Doesn't come to my mind. And so you have next one is 3 days to I want to say maybe like a week or 2 weeks. And this is where the macrophages come in. They kind of so macrophages, they want to build the tissue back up, but also remember that macrophages have this thing called metalloalloprotease, right? If you want to build it up, a lot of times you got to degrade what's already there. And also, what do macrophages do? They eat a lot of shit, right? So they kind of destroy and eat a lot of the debris that causes weakness of the physical weakness of the heart. So you get a lot of like structural problems with the heart. You get a lot of times that the heart's gonna stop, like pops, right? Literally bursts at different places. Now, depending on where it bursts, you get different symptoms. So imagine this is your heart. It might burst here. You might get a kind of a ventricle septal defect, right? It might burst here. What happens? You get a shit ton of blood in the pericardium. You get acute tamponade. So this is your heart, right? This is your pericardium here, the bigger. So you get a lot of blood here, acute tamponade. You die, right? Then the next one is kind of interesting. Remember these papillary muscles? These guys, where was it? These guys. So the heart, let's just draw the left ventricle. So this is the mitral and this is like the aorta. So what holds these lips together is a bunch of fibers, right? And these fibers are attached to kind of like mountains of muscle. They're called papillary muscles. Papillary means finger-like. So these muscles, if the infarct or if the macrophages come here, they will kind of a lot of times destroy this, and so you might like one of these gets popped, and then you get what? You get a severe mitral regurgitation, right? All right. What else can happen? The last thing that can happen is what happened here is like you get like basically this is like during fibrosis, you get kind of like weakening of the walls, and the weakened walls they won't pop, but they will expand. They'll just like they get elastic, right? So your heart, instead of looking like, let's just draw the left ventricle again, instead of looking like this, like it just starts looking like this, like looks like, I don't know, it looks kind of fat, but then also this is thick and muscular and like can actually pump blood. Let's say this is thick here and thick here, but then this is where the infarct happened. It kind of gets like really skinny here, right? And it keeps expanding because it just this tissue isn't strong. What the problem with this is that obviously the heart isn't able to pump as much, and the other thing is that it forms a thrombi here, forms like because there's abnormal blood movement. Thrombi forms here. Next thing you know, thrombi goes back up, gets lodged in the brain arteries, and then causes a stroke, an embolic stroke, right? No, why did you choose that? This D. All right. 17-year-old comes to an ER. Okay, so this is a classic example I described earlier. Like a young guy, kind of like faints, and when he's young after exercise. Right? This is I'm not gonna read the question. This is hypertrophic obstructive cardiomyopathy, right? It's the left ventricle hypertrophy that gets bigger, basically, right? So when you say young guy died at an early age, two causes can lead to this. This is one of them. The other cause that I don't think is covered in your curriculum yet is a channelopathy. Interesting name, eh? Channelopathy means a problem with the channels. So you can have mutations with the sodium or potassium channels, and they cause they put you at a predisposition to torsade point, Okay. Fuck, this bird just flew right past my face. Okay. Let's look at this one. 30. What was the answer? Alright. Probably interesting condition. Okay, so you got 30-year-old female, amenorrhea, and then I know it's Turner syndrome, but I want to look for the the clues that it gives you. This Turner syndrome. Web neck, got a webbed neck, which I show you what it is really. If they show you in a photo, so usually your neck looks like this, a web neck, like they got mad traps. This is like a web neck, right? But like it's not muscle, it's just literally just extra skin, a lot of it. You can Google a picture. I encourage Googling pictures because like at some point you're gonna like see it in a patient, even like in higher order exams you're gonna see it in like a picture in an exam, and you're not gonna know what it is. So a bunch of things that can happen to these guys is that, well, most important ones, again, let's try the left ventricle. So this is the mitral, and then this is the aortic valve. The aortic valve has kind of, if you look at it from this angle, if this is your eye looking at it down here, you'll see kind of like a Mercedes logo, because it's like three leaflets kind of like touching each other, and then when the blood comes in, it comes in like from like it opens these gaps and comes in, right? But in these guys, it looks like this, but one of them is actually fused. So that's like it's fused here. So when it opens, like it just like this one opens only, right? And this is called a bicuspid aortic valve, right? And the problem this has is that over long term, it predisposes you to a lot of stuff, like a aortic wall tear, like the tear I showed you here. This tear, the one with the false lumen, here, this one. So hypertension here, I forgot, bicuspid valve, right? And a lot of people with Turner syndrome have it. The other cardiac complication that a lot of Turner syndrome people have is what? Is coarctation of the aorta, right? So let's draw this aorta out. It comes out here, you know, it gives some vessels here, here, and here, 3 vessels. And then it might be coarcted, meaning like it might be closed here, right here. And so the way you see this is that you get like kind of a weaker pulse in one of the arms, or you get a difference of blood pressure in both arms, or you get weaker pulse in the lower limbs. So watch out for that as well. That's associated with Turner syndrome. So this is where I stopped reviewing it. I think what those highlights were, that it's just me reviewing the questions. I'm gonna like look at the answers before like forming an opinion on the question, because I don't wanna. Again, these questions aren't the best, but they're the best you have at like as a term 4 level. So I don't want to just like explain it how I would, because I might get to the wrong answer because the choices aren't the best. So 35-year-old, 1 month history of weakness in the upper extremities, visual disturbances. Okay, weakness upper extremity. Okay, physical examination uses weak pulse bilaterally. What are you talking about? Okay. Upper extremity weakness, visual disturbances. Oh. I get it. Asian. So this is Takayasu's arthritis. Or arthritis. Or aortitis. Takayasu's aortitis. Common in kind of like 30s Asian females. Is a vasculitis. Is it? So let's check the answer. Yeah. It's a vasculitis of the kind of your bigger vessels. It's kind of similar to temporal lobe arthritis. But temporal lobe arthritis happens more in the elderly, and it happens like on the like in the temporal artery and its branches. Right. This happens more in the aorta. But there's some crossover. That's why this girl is having visual disturbances. Weak pulse, and then you get weak pulse because remember the aorta comes off, right? It has 3 branches, if you have arthritis around here, right, blood is not getting into these, so you get like low blood pressure, uh, low blood pressure going into your arms and shit. So you get like you get lower lower blood pressure measurements, right? Now, what's the mechanism behind it? I say mechanism instead of mechanism, and my buddy always makes fun of me, so I'm gonna try to say mechanism. So what's the mechanism behind this? Is a giant cell. So it's a granulomatous arthritis. So you have granulomas, right? And it causes a lot of intimal thickening, right? Because you have inflammation, right? And the way I remember this granulomatous is that, hey, it's similar to temporal lobe, temporal arthritis. Temporal arthritis, the other name for it is giant cell arthritis. And so I remember it's granulomatous, right? So is here, like, so it's not non-granulomatous. Segmental necrosis is more associated with maybe polyarthritis nodosa, if maybe that's what they're going for. Medial thickening, I don't know what it's going for. Let me think. Medial thickening. Honestly, maybe this is also temporal arthritis. Duplication, this is a little interesting. I don't remember duplication anywhere, but I think these two both, they kind of destroy the IEL and EEL. But for this answer, the answer is thickening and wrinkling of the arteries. So 16-year-old boy, let's look at the answer. Okay, oh, good. It has the name of the genes that I can talk about that I couldn't remember earlier. Again, so 16-year-old guy just dies after playing, you know. Uncle had the same shit, right? First of all, I don't like how the question is saying uncle, because it's an autosomal dominant condition, right? So when you say uncle, you're trying to say this is X-linked. It's not X-linked. It's autosomal dominant, right? Now let's talk about these. Fibrillin 1 mutation. What is that? Did you see that? See that in a connective tissue disorder that kind of has problem with. So fibrillin is what cross-links elastin. So these guys have problems with elastin. Now, what is this condition? It causes mitral valve prolapse. It's, what is it again? It's Marfan's, right? Marfan's. You got, so these two are my favorite, right? Oh, actually, let's look at the. So Coxsackie B infection can lead to myocarditis. So okay, myocarditis means inflammation of the heart, right? That's what it is describing. Now, some certain outcomes might come out of that. Your heart might just stop. You know, you might get chronic heart failure. You might get better, right? So myocarditis doesn't really like isn't. I guess you can have several outcomes coming out of that, right? Troponin T mutation. I don't even know what that causes, but to be honest, both A and C can cause this. A and C, right? This is again hypertrophic obstructive cardiomyopathy, right? So both A and C can cause this. But it chose A. You won't see both of them being as answers unless like there's something like, I don't know, like they made, like, it's not, unless this is made up. But there's something like some protein C that also has the same role. So this is, if you remember early on, we did a question, like I think the first question of this video, we did this question that was like, let's see how much my recording has been. It's probably long as fuck. I'm probably gonna end it soon. But yeah, these are the two genes that cause hypertrophic obstructive cardiomyopathy. Right. 30-year-old woman, shortness of breath, 3 episodes of fainting, CT shows pedunculated. So okay, I don't like this question because the woman is too young, right? Too young. So this is my soma question. Let's try the left ventricle, my favorite ventricle again, right? This is the atria right here. This is the valve. So myxoma is like a pedunculated. It's like kind of like pedunculated means it's on a like peduncle right there. So it grows like this, right? It's kind of like a mushroom, and it kind of moves around. It kind of bounces back and forth in each beat. So a couple of things that it does. So none of them are really explained well here. Yeah, fainting maybe. Okay, so when it goes back and forth, sometimes it blocks this. So sometimes you get like low cardiac output, right? That's one thing. Yeah, it's myxoma. The other thing it does is that it's kind of like pieces of it come off and it causes stroke, right? The other thing it does is that it secretes a lot of IL-6 and inflammatory stuff, so it kind of gives you like fevers and stuff like that. Let's see if this doesn't have that, right? Oh, and on pathology, it has the descriptor they use for this on pathology is kind of like it's hypocellular. It means like there's a lot of extracellular matrix in it. I don't exactly know what those like. It's myxoid, so it has a lot of random stuff in the extracellular matrix, and that's why it kind of comes off because it's not a lot of cells. Now let's look at this. We got 18-year-old. Let's see how much battery I have. 25. We got time. 18-year-old, intermittent headaches, muscle aches, fatigue. Is markedly elevated. CD angiogram for left renal artery stenosis. It's a guy. Transmural inflammation. Okay, fibrinoid necrosis. This is polyarthritis nodosa or PAN, right? First of all, fibrinoid necrosis is characteristic for this. What is fibrinoid necrosis? It's kind of like the necrosis of a vessel, right? On pathology, it looks like a vessel, and then there's like pink stuff in it. There's like a lot of pink stuff in it, and it doesn't have any cells, so it's kind of like dead stuff, dead like protein, right? You also see it in like malignant hypertension, which is like super high hypertension. It's associated with hepatitis B, and the way that works is that in the case of hepatitis B, these proteins are like antibody plus antigen, so antibody antigen complexes that are just like participating anywhere in the cell, and it causes these. Classically, polyarthritis nodosa kind of skips the lungs, so your lungs will be fine. But also classically, you'll have, it's kind of like, if this is your vessel, it's not everywhere. It happens here, you get a dilation, and it happens here, you get a dilation. So it kind of looks like beads on a string thing, and it looks like that on kidney, right? Yeah, that's all I really need to know about it. So we got, what do we got? We got a 60-year-old woman, blurry vision. Okay, I'm already thinking of what? Temporal arthritis, but weight loss. Okay, why weight loss? Because it's a systemic disease, right? It's like releasing a lot of cytokines, so it's putting your, why not make these bigger? Putting your body in a kind of a bad metabolic spot, so it starts using a lot of its things. Decreased visual acuity, okay, so she can't see properly. Also, it hurts. Important, you have elevated ESR. ESR is just a general sign of inflammation, so it's like systemic inflammation going on. And then what do we see? Do we see infiltrating lymphocytes? Do we see collagenous fibrosis? Do we see fibrous necrosis? What? PAN, right? It's a so temporal lobe. Let me actually check. Yeah, temporal lobe arthritis, not temporal lobe, temporal artery arthritis. Also, other name for giant cell arthritis. What is a giant cell? It's a cell that's seen in a granuloma, right? You have granulomatous problems. Now, is it caseating? Okay, autoimmune disease don't cause caseating granulomas. They cause non-caseating granulomas. What is caseation? Caseation is a type of like fat that looks like cheese, right? When do we see this? We see this in TB and some sort of fungi. Why? Because those organisms produce this type of lipid that looks like that fat, right? So when you don't have the organism, when it's a purely autoimmune condition that you'll have a lot of them, right, in the future, it's going to be always non-caseating, okay? Let's look at this question. 25-year-old, 25-year-old, muscle weakness and rash, unprotected sex, multiple partners, diffuse macular rash, palms and soles. Okay, that sounds like, okay, broad-based gait. They made a bad question again. So, but I mean, this is syphilis. Syphilis happens in multiple phases. Syphilis happens primary, secondary, tertiary syphilis. This guy has primary, secondary, and tertiary together apparently. So the rash in the hands and feet is primary, secondary. Primary syphilis is just the initial site, that like initial wound, right? Secondary is the hands and feet rash and stuff like that. Tertiary is neurosyphilis. So you got the broad-based gait, positive Romberg sign. That's because you have with the so if you remember, the proprioceptive information from the spine isn't like it's getting destroyed. So your body doesn't know like where the like joints are. Like the proprioceptive information is out, so you're not feeling shit. Like the Romberg sign is if you close your eyes, you're gonna fall because you don't know, there's no proprioceptive information going up. That's why he's walking a little funny. But that happens later in life, not in 25. That happens like if you get syphilis at 25, it happens when you're 45, 65, right? And that's why it's kind of insidious, because like you get it, your body clears it out, but then the autoimmune reaction kind of like over time kills like your neurons and stuff like that. And you also have like some findings with your pupils and stuff like that. It's tertiary neurosyphilis, right? You also have something known as guams or some stuff like that. It's just loci of destruction. So it just literally, I don't know how else to describe it. It's just like, I don't know, let's say there's like a massive destruction on your face. Maybe you can look that up. But that's also associated with tertiary syphilis. Now it says, oh, beautiful. So spirochete atrophy involving only, remember I said with syphilis, I'm gonna draw my favorite ventricle again. So you got the aorta coming out, and then these aorta, because it's a thick vessel, it has a vessel feeding it. It's called vasa vasorum. So vessel of a vessel, you know, in Latin or whatever. So it kind of like destroys the syphilis, and that's why you get like that, like you get kind of aneurysm here, right? If it's not B, I'm gonna, oh actually, spherical, no. I thought that, no, I meant C, right? You're losing your vasa vasorum, right? That's why the other complication of this is cardiovascular, like dilated cardiovascular, and you kind of like put a lot of like over time you're dilating this valve because it's just like stretching it from both sides. When this thing grows and kind of like gets bigger and bigger and bigger, kind of like starts pulling on the aortic valve. Right, okay. Beautiful micro question coming up. I remember the micro really fucked me up for cards because I didn't remember it right away, but kind of gonna know this. SG puts a lot of emphasis on micro and form. They're not a big part of STEP. Know your pathology and physiology really, really well. That's what's important. Don't memorize it, understand it. So we got a female unconscious on the street. Kind of like this is just like means unconscious. diastolic murmur heard at the sternal fourth intercostal space. Kind of a little bit of fever. Vegetations on one of heart valves. Beautiful. One. Any. Like. So we saw it in a scan, but we don't know which valve it is. What an unrealistic question. I don't even think this question gives you enough information to reliably track marks. Oh, track marks. What the fuck's a track mark? Okay, so where is this? This is where like they take blood from you, right? It's also where like IV drug users inject drugs. So this girl is an IV drug user. So IV drug users get myocarditis, but where do they get it? They get it in a tricuspid. So let's draw my less favorite ventricle, my right ventricle. And because this is the veins, you know, they bring all the blood back, and they inject the drug into their veins, obviously. So if it has organisms, it's just gonna directly affect this, right? And then it goes to the lungs and get cleared out, so you don't get it in the left ventricle really. But you get tricuspid regurgitation out of this, right? Tricuspid regurgitation. What organism do you usually get? Well, whatever is on your skin, really, right? Because they don't properly use a needle and shit. So you get Staph aureus. So is it a gram-positive? Yes. Is it a cocci? Yes. It's the staph, right? Staph organisms, remember this, please. Staph organisms are all catalase positive. How can you remember this? Remember the I guess what can you connect this to? Remember there's chronic granulomatous disease of childhood, right? These guys don't have like an enzyme that allows their neutrophils to do a respiratory burst, so they can't kill the bacteria inside them because they can't produce those superoxide, those like harsh chemicals that kill the bacteria basically, right? And if you remember, those guys still can kill strep organisms, but they can't kill the staph organisms. Why? Because the staph organism produces catalase. Both of these guys produce H2O2, right? Which is like kind of like bleach, right? Because all living organisms that use oxygen produce some. So in the case of strep, it doesn't have catalase, so some of the H2O2 makes it to the cell, and the cell uses the bacteria's H2O2 to make bleach and kills the organism. But staph has catalase. Catalase breaks this shit down, so staph doesn't release any H2O2. So that's why when you're talking about catalase positive organisms, people with chronic Graham's disease of childhood, they can't kill the catalase positive organisms, right? So that's how I remember that staph is catalase positive, right? So it's one of these choices. Also, the thing that separates Staph aureus from any other type of staph, what is it? It's it being catalase positive. So the answer is A. How much battery I have? 21%. We got a kind of young male in the ER, fever, whatever. Again, cholecystectomy. Okay. Again, you got a bad question here. No, it's okay. But same concept. Guy's a drug user, gets murmur. What is it? Staph aureus. Why? Because that's what lives on the skin. 27-year-old woman. Joint pain. Seems to be spreading. It kind of moves around. Limbs jerk out of... This is Sederman's chorea or whatever. So joint pain, Sederman's chorea. So what is this? This is kind of like post-streptococcal pharyngitis, right? But it's happening acutely, maybe. EKG anti-ASO titer. So, yeah, rheumatic heart disease, right? You get strep, pyogens, or group A strep coming in. It has an antigen called M protein. Your body wants to clear this shit out. It makes an antibody against this M protein. It happens to cross-react with some of the stuff in your body, so it causes a bunch of like autoimmune things, right? One of them is it causes problem with the heart, right? Let's see, patchy, right, and that causes acute myocarditis, right? Acute myocarditis after infection. The other thing it causes like the joint problems, right? What also it causes this movement disorder, Sitterman's chorea or some shit like that. But on histology you see like kind of like granuloma looking stuff. So it's like areas like if this is the like myocardium, these are the fibrils. You see like bunch areas where there's like a bunch of like cells, kind of like immune cells that aggregate, and some of them have like these like kind of like linear looking nuclei, right? So let's see what kind of points to that. Interstitial fibrosis, no. Focal necrosis of myocyte cells containing wavy chromatin. This is what it's talking about. So you get kind of like a granuloma, but it's kind of looks like it's an immune reaction to the heart, right? But this is what is characterized. So it has like a wavy chromatin. So the guy has Staph aureus. Like there's a okay. Why is Staph aureus resistant to methicillin? Right. Staph aureus is a very interesting organism. Right. Two ways it can be resistant. Right. One of them, like base price Staph aureus, the very basic model of Staph aureus is already resistant to a lot of antibiotics, a lot of penicillins, and we use special types of penicillins for them, and that is because they break those down. So the way base model Staph aureus is resistant to antibiotics is that it produces beta lactamases, right? But methicillin resistant. Methicillin is like a what is methicillin? I'm not even sure. Oh, well, methicillin. So some of the so remember the base model already resistant to a lot of beta lactams. So we make a beta lactam that's kind of like bulkier, so this beta lactams can't work on it. Methicillin is an example of that. The other example is nafcillin. They all end with cillin, right? Now it gets like this time the kind of like the better version of Staph aureus, the methicillin resistant one, it doesn't rely on beta lactamase anymore. It just has a completely different penicillin binding protein. Remember, the penicillin binding protein is the protein that produces the cell wall in these bacteria, right? So it just has a different version of that penicillin doesn't work on it at all anymore. So we use other drugs. What we use something like vancomycin, we use daptomycin. These are just like other drugs. I don't know if you've read it. Probably not. You haven't read about them. No. Okay, next question, please. Please be above 20%. Close. 75-year-old man, colonoscopy. Oh, okay. So I'm not gonna even read the question. I know what it's gonna be about. When you have colorectal cancer, you have a chance of getting strep bovis infections. What is strep bovis? I'm not exactly sure, to be honest with you, but whatever this question says, I guess. Is it a catalase? I can tell you this. It's strep bovis. Strep. I just gave you a lecture about why if it's strep, right? It will be catalase negative. Catalase negative. Growing in 5% 6% NaCl. This is enterococci, right? Up to chain resistant. This is viridins. So I think it's D. I may be wrong. So it's C. It does grow in 6.5% NaCl. So the way you can think about that is that all like the gut bacteria are kind of able to do this because there's a lot of shit that happens in a gut. Actually, I don't know. Just memorize it. It's micro, no good reason. It's not a high yield organism, but it has a new name. It's not called bovis anymore. It's called like some fancy shit. But just know that 65-year-old man, difficulty urinating, it has CVA, symptoms after discharge, right side of the facial droop. Okay, has it, whatever. We get the idea. Okay, and then he can pee. Wait, so why can't he pee? Or which of them, what can help him? So he's had a stroke. The neurons that are responsible for relaxing, so by default, like your lower motor neurons, a lot of them by default lead to hypertonicity, right? High tone. On your muscles, it literally means like they won't move as freely. That's why if you had a upper motor neuron problem, your lower motor neurons will cause hypertonicity. On the bladder, it means it won't be able to pee as much, right? So this guy has a problem up there. The lower motor neurons are keeping the bladder locked. So you want to give him something that overcomes that, right? You want to give him something that opens the kind of, either opens the bladder, or actually what would be better for him is to contract the detrusor muscles, right? So if you want to contract the detrusor muscles, you give him botanical, because it's a what is it? It's a cholinergic agonist, right? Remember that the problem they're having is really that like the detrusor isn't contracting. Okay, so go with botanical over prazosin. So it's an interesting case. We got a 32-year-old woman for bypass surgery, and then she can't pass urine again. Descended bladder. What drug caused it? It's probably a muscarinic antagonist. Oh, use to relieve. So the drug that caused it is probably a muscarinic antagonist. How do you relieve that? You want more acetylcholine. So you give something that blocks the enzyme that blocks acetylcholine. Cholinergic agonist works in theory. Actually, not in theory, because you want, it's about muscarinic activity, right? That's more specific, muscarinic, because the receptors are M3 receptors that are on the bladder, right? So you want to activate those. Cholinergic means like anywhere we have acetylcholine receptors. It could mean on the nicotinic receptors, everywhere, right? But C is a better choice. You won't see questions like this in the USMLE. Okay. From this I can tell she's diabetes from what I see. Yeah, diabetes type 1, right? What happens? What does she take that? Oh, I think it's physiologic, no? Yeah. What triggers the diabetic shock? Is it the shot of okay, so diabetic ketoacidosis, whatever, right? Diabetic ketoacidosis. Remember, if you let me think of it this way. If you don't have enough insulin, your liver thinks you're starving, right? And then it produces ketone acids. But if you have diabetes type 1 specifically, the reason you don't have insulin isn't because you're starving, is because you don't have a pancreas, working pancreas, right? So it produces keto acids. That's why you pee, and then your sugar goes up. That's why you pee a lot. That's why you, I mean, it explains a lot of stuff, right? Now, it also explains the fruity acetone-like odor. This can be triggered by what? It can be triggered by your epinephrine, because epinephrine has kind of like same effects than glucagon on your liver, right? Remember, glucagon is activates CAMP. Guess what? So does epinephrine, right? So, and what is this effect of like the relationship of epinephrine with insulin? Then it's kind of like same with glucagon and insulin. Is a physiologic kind of an effect, right? What would be an example of chemical? This is when heparin and protamine sulfate, right? It binds heparin basically. Heparin has a negative charge. It just literally binds heparin, blocks it until like you're good. 34-year-old female, ventricular arrhythmia, joint pain. Okay, whatever. I get it. So it's A, no? So prokinamide. The patient goes on prokinamide and then gets lupus. That's what you have here. Love this question. Love this question. Actually, instead of reading a question, I'm going to explain what each one of the No, let me actually do it. So you got before alpha blockage, after alpha blockage. So before alpha blockage, your blood pressure goes up. Then what is this? What's the options between this and this? God. What's the difference between these two? Okay, whatever. So it's a drug that usually causes increasing blood pressure. I'm just gonna be looking at this, right? And if I'm wrong, it just means like the question says other stuff that I haven't read the question. So the drug causes increasing blood pressure, but then when you block alpha, it causes decrease. So what causes increased blood pressure is alpha receptors. What causes decreased blood pressure is beta 2 receptors. These are both alpha 1 and beta 2. These are both on the vessel, right? So this drug probably kind of does both, right? And then when you have alpha, so this brings it down, this brings it up. When you have alpha blockage, it only like does this. So when you have alpha blockage, it only does this, so it lowers the blood pressure, right? Labetalol is an interesting drug. What it does is that it decreases beta 1 signaling. It also decreases alpha 1 signaling, right? So it relaxes the vessels. It also relaxes the heart. It's really good for everything, basically. Metoprolol is a beta 2 blocker. It doesn't really go with this question, right? Atropine, this has muscarinic problems and stuff. Yeah, that's what I was thinking. So norepinephrine doesn't interact with beta receptors at all, I think. Epinephrine does. Norepinephrine doesn't. That's why norepinephrine is a better vasoconstrictor, because it doesn't have the vasodilative effects of beta 2. But you have phenylephrine that has alpha 1 and beta 2 activity, and that's your answer. Phenylephrine kind of acts similar to your epinephrine. much battery. I'm gonna do this question and then go in and finish it off. We got a 55-year-old female. Pansystolic murmur. Vegetation on mitral. It's a case of a lupus, right? And E gives you lupus. I don't know why people chose A here. I'm gonna do this too. 74-year-old. Actually, yeah, I already started it. So, has heart failure, reduced ejection fracture. You give him a drug that is also controls AFib. I'm honestly thinking D. Magnesium. The reason you don't give D really is that the heart might be too weak. Oh, toxicity of this antiarrhythmic. Palpitation, numbness, vomiting. Okay, I'm gonna come back to this. I'm gonna go home because the sun is on my face right now. Put my laptop in charge, and also I'm gonna plug the camera in so you can see my face. Alright, peace.